Today, my topic is strategy for recurrence after liver transplantation for the advanced SCC, especially in the era of the expanded criteria. In expanding the Miran, the size and the number expansion was initially proposed. However, in the recent expanded criteria, biomarkers such as AFP, DCP, NLL, and FGPET were included. The importance of size and number has become decreased. We recently proposed 500 criteria, which was based on the 1,122 liver transplantations for HCC in Japan. The expansion was aimed to achieve more than 70% 5-year patient survival and less than 10% recurrence rate. The performance of 500 criteria was similar with Milan. In addition, 500 criteria can clearly stratify the recurrence risk. Now, in Japan, the double eligibility criteria 500 or Milan is officially approved as the indication for liver transplantation for HCC. However, as metal ticket paradigm described, any expansion of indication will lead to increased risk of recurrence. So we have to be more ready for the recurrence after liver transplantation in the era of the expanded criteria. The management for post-liver transplant recurrence consists of prediction, prevention, surveillance, and treatment. There are several nice prediction models. These scoring usually includes pathologic findings of explant livers with or without biomarkers. At present, these predictors are considered and accepted as useful in predicting the HCC recurrence. These prediction models are not only help the identification of patients with high risk of recurrence, but may also be useful in the development of standardized surveillance protocols and in the identification of patients that should be considered for adjuvant therapy given their particularly high risk of HCC recurrence. Prevention is basically based on the immunomodulation. Adjuvant chemotherapy is not recommended at present. Among several immunosuppressants used for liver transplant recipients, mTOR inhibitor has a unique anti-oncogenic effect. Calcineurin inhibitor has definitely pro-oncogenic effect. A few retrospective studies demonstrated that decreased calcineurin inhibitor may decrease the recurrence of HCC after liver transplantation. Regarding mTOR inhibitor, the results are conflicting. Meta-analysis and large database study once supported the efficacy of mTOR inhibitor used for HCC recipients. In contrast, recent randomized control study did not find the positive effect of sirolimus in preventing HCC recurrence. Recently, Spanish group also reported that everolimus did not decrease the recurrence of HCC after liver transplantation. Assam Medical Center group reported the use of mTOR inhibitor improved the survival among those with recurrent HCC after liver transplantation. Recent report of 2 international RCT of everolimus found no significant effect of everolimus on HCC recurrence. However, the recurrence rate tended to be lower among beyond HCC group. In summary, CNI reduction coupled with the mTOR inhibitor can be considered not only for renal protection but also for reduction of HCC recurrence. For SCC, mTOR inhibitor can be used as immunosuppressants to reduce the risk of post-transplant SCC recurrence. However, there is no robust evidence to support recurrent HCC cases. It is recommended to introduce mTOR inhibitor together with CNR reduction or withdrawal due to its combined immunosuppression and antiproliferative properties. This is a summary of characteristics of HCC recurrence among liver transplant recipients. Mean recurrence rate is 16% and the extrahepatic recurrence rate is around 70%. These recurrences occur within 2 or 3 years in most cases. And overall median survival after recurrence is 13 months. The favorable profiles are late recurrence, low AFP value at recurrence, and feasible for surgical resection, including local lesional treatment. Surveillance to detect the recurrent HCC at the stage feasible for local lesion treatment is essential, especially within 3 years after liver transplantation. In the surveillance for recurrent HCC, we follow the guideline proposed by Japanese Society of Hepatology. Tumor markers were checked at every visit about once a month, and dynamic CT is recommended every 3 to 4 months within the first year and every 6 months for 3 years after liver transplantation, once a year thereafter. So far, we performed 165 liver transplantation for HCC patients, and majority of patients were child C or B. The most frequent etiology was Hep C. Over 80% of recipients had been performed prior treatments for HCC. TACE was most frequent, followed by radiofrequency ablation. In the cohort, 85% were within Milan and 92% were within 500. Totally, 15 patients developed recurrent HCC. The recurrence rate was 9%. When we look at the cause of death among HCC recipients, de novo malignancy was the leading cause, followed by HCC recurrence. This is a summary of patients with recurrent HCC. 67% was extrahepatic recurrence, and the median time to recurrence was 10 months. All recurrence was diagnosed within 3 years after liver transplant. Our results were consistent with other centers. So, of course, surveillance is important for liver transplant recipients for HCC. We should also be careful for other aspects such as de novo malignancy, recurrence of primary disease, rejection, infection, etc. Regarding treatments for recurrent HCC, surgical resection, including local lesion treatments, is the first choice if applicable. Systemic treatment with tyrosine kinase inhibitor, such as lenvatinib, sorafenib, regorafenib, is indicated for unresectable recurrence. This is a summary of reported cases of post-liver transplant malignancies treated with immune checkpoint inhibitors. The disease control rate was only 21% and the rejection rate was 35%. So immune checkpoint inhibitors are now considered contraindicated among organ transplant recipients. Sorafenib and lenvatinib are the first-line systemic treatment among liver transplant recipients with HCC recurrence at present. Lenvatinib was approved for clinical use for HCC in March 2018 in Japan. We used lenvatinib in 2 recent recurrent cases. The first case, 50-year-old male, Hep C and Hep HCC. While the liver function was preserved, the short span HCC recurrence led him to limiting donor liver transplantation. The 4 nodules, maximal diameter 25 mm at the time of liver transplant. Maintenance immunosuppression was composed of low-dose TAC and everolimus. 1 year and 10 months after liver transplant, recurrent HCC in the graft was pointed out, and the partial resection was performed for 3 nodules. After 2 years and 4 months, recurrent HCC was again observed in segment 7, at this time solitary, and the case was performed followed by lenvatinib. This is the images. The upper images are the first recurrence in the graft, and the lower images were second recurrence. This is a time course with tumor marker trend. Complete response is maintained for 18 months with lenvatinib in this case. The second case is 64 years old male, hep C decompensated cirrhosis with hepatocellular carcinoma beyond Milan. He was also performed living donor liver transplantation. Also, maintenance immunosuppression was composed of low-dose TAC and everolimus. 1 year, 11 months after liver transplant, recurrent HCC was found in upper lung, left upper lung, which were resected by video-assisted thoracoscopic surgery. 3 years after and 4 months after the liver transplant, local recurrence and lymphometastasis in the mediastinum was observed. At this moment, the lesion was unresectable, so lenvatinib was started. Left side is the first recurrence in the left upper lung, which was resected, but after the 2 years after the lung resection, local recurrence and lymph node metastasis was observed. 3 months after the initiation of lenvatinib, the local recurrence shrank and the intratumoral enhancement was attenuated, as shown in the slide. This is a time course with tumor marker trend. Partial response is maintained for 8 months after the initiation of lenvatinib. This is a summary of these cases. Lenvatinib seems effective in controlling the disease progression of recurrent HCC in liver transplant recipients. Taiwan group reported 10 cases with HCC recurrence after liver transplantation who were treated with lenvatinib. The efficacy and safety of lenvatinib was comparable with non-transplant HCC patients. This is my conclusion. Prediction model will be helpful for the intensive surveillance for those at high risk for recurrence among liver transplant recipients. mTOR inhibitors may be useful after liver transplantation for HCC, but the benefit of it is to be determined. Lenvatinib may improve the prognosis of post-liver transplant patients with HCC recurrence. Thank you for attention.